star. I see hot bras, like hard stop. Swerving your bay in my coupe. Swerving your bay in my coupe.
What is up, YouTube? Or should I say Moni Flexx Squad? It's your girl Moni. Now, if you guys have been on this journey of me being ill and me having the surgeries, you guys will know that in May I had my full colon removed. So, it's been 3 months, you guys, because I am on my way. Well, me and Flexx and my mother are on our way to the hospital to see my doctor. And we're going to discuss about how I've been doing and when's the next time I'm going to have my surgery. So, you guys, it's been a long journey and I'm almost at that finish line. And you guys just don't know how good it feels to be able to move to the next step with this whole surgery process so I can get the J pouch. Like, you guys, it's been tough. I've been dealing with a lot, I'm not even gonna lie, but I've been pushing through, you guys. So I appreciate all your prayers, your sweet comments. Like, I see it all. Trust and believe, I do. So I'm not going to like show the doctor like face and all that, but you will actually hear them talking to me. Just bring you guys along this journey, and I just want to hear good news today. To be honest, I don't want to hear nothing bad. I want to hear everything is going well, everything looks fine, so we can do the next surgery. I know with getting this J pouch, it's going to be a lot. And I'm going to be in a lot of pain. But I want to be, even if I had to have my back permanent, I want to go down this J pouch journey just to say I did it. Don't forget to like this video and make sure you subscribe. And don't forget to share. But yeah, so the next time I will get on, I'll be in the room recording, and hopefully I get good news. So yeah.
My understanding, you have colitis, whether that's Crohn's or ulcerative colitis. It's ulcerative colitis, not Crohn's.
Yeah.
Okay.
For a while there, it was Crohn's, where it was up in the air with Crohn's.
Yeah,
because my last doctor, that's just a long story, but yeah,
okay.
It's UC now.
It is for sure UC.
Yeah.
Okay. So, long story short, you tried medical therapy, it didn't work. You saw Dr. Valentino. He took and did a diverting loop ileostomy in January. Yeah. Continued to have symptoms, so he took you back to the OR in May. And at that time took out your whole colon, and then just gave you an endoileostomy. Mm-hmm. And then I know that you saw him back post-operatively after that, and things seemed to be going okay, but then he wanted to see you again in a couple of months, which brings us to now.
Yeah.
It sounds like you're still having pain around your bottom, right?
Well, just recently I had like it felt like pressure, like I had to go to the bathroom. Yeah. Nothing would come out. And so I kept calling here and Dr. Siderico's office, and like I wasn't getting any answers. So I went to the ER. Yeah. And they did a CAT scan, and they were like, "Oh, well, you have some inflammation. It's not infected or anything, which is good, and you just have some inflammation down there." So I said, "Okay." So he gave me some prednisone. So I called here, and Dr. Siderico, and they was like, "Stop taking that right now." So I stopped all of that, and she put me on some medicine. So
suppositories. That
and also some pills. It starts with a B, I want to say. Yeah. It has, maybe, I think that sounds about right. But I've been taking that. She's weaning me off of it. I'm not having.
I don't really want you on that before we go to surgery either. It does not have as much of a systemic effect, but I also, anything that's happening with regard to your inflammation down around your rectum would be from a systemic effect, because it's not in circuit. And so I don't know that I really want that one on board. Okay. I want no form of steroid if at all possible. when we're going to an operating room, or if we're going to an operating room here?
Yes, well, since then.
Doing better?
Yeah, I'm doing a lot better.
What kind of suppository did you end up with?
Canasta.
So let me start with that exam while we're at it. Take a look at your bottom too.
Okay.
Working okay for you?
Yes.
How about your belly pain? Are you having much in the way of belly pain anymore?
No.
Good. Just pressure around your bottom? Do you have any pain or bleeding down there?
No. Not, I was, before she did the Flexx, and she noticed that I had like a fish, and so she gave me some cream for that.
So all better?
Yeah.
Overall, following your surgery, you're feeling a lot better than you were
A lot better.
before?
I'm only going out my bottom maybe once a week, and when I do go, it's not much. And it's like a brownish, darkish red that comes out, and it's just a little.
How we're gonna, or the options for managing your disease. There's been this question, ulcerative colitis versus Crohn's. I haven't seen anything definitive about any of the records. There was always that one endoscopy report that no one's really been able to locate, but was referenced the one time. And so, I think at this point, for just to kind of recap, the options are to leave a permanent ileostomy. We can remove the rectum if it's symptomatic, or we can talk about going forward with the J pouch. I haven't seen anything that makes me think that that shouldn't be an option for you. Okay. The things, your initial specimen didn't really show much in the way of a lot of chronic disease out of your colon. But we have seen evidence of inflammation that's extended up to your splenic flexure. The good part is that we also didn't see anything that would indicate that you have Crohn's. Your flexible sigmoidoscopy does still show active and chronic proctitis, at least. So we're seeing evidence of chronic inflammation down low. And when they examined your small bowel, we're still not seeing any evidence of disease in there, which is good. So again, all things pointing in your favor. It is still possible we could discover a diagnosis of Crohn's later on. If it does, pouch failure rates are going to be substantial, and we may be forced to have an endoileostomy at that point. And the downside to discovering that later on is if you start having fistulas or other problems down there, it may cause some problems with your perineum, with having extra holes around your bottom. Really more importantly though is that we've lost some additional gut length because I've used a segment of small bowel that we would have left in circuit. Now I've used it to create a pouch. Okay? You understand all those options?
Yeah.
And we've talked about them pretty at length, I think, in the past.
Yeah.
Still feel like you want to move forward with a pouch?
Yes.
With regards to timing of surgery, the other big thing, especially in young women, I always bring up is the effects that it can have on fertility. If your initial surgery, especially when we do it laparoscopically, we're probably not creating a whole heck of a lot of scar tissue down in your pelvis, so things are probably still relatively close to normal. What we think happens is when we go down and do a big pelvic dissection, it creates the scarring across what are called your fallopian tubes, the road that goes from your ovaries down to your uterus. And so, us going down and doing a pelvic surgery may decrease the chance that you're able to get pregnant. It doesn't make it impossible, and we also may still be able to overcome that with other fertility assistant treatments, but it is definitely a consideration. So we've talked about that before as well. Still okay with it? Want to go forward? All right. Just to recap then, how about I have you stand up? We'll draw you that picture one more time, make sure you understand. What we did is we took the ascending, transverse, descending sigmoid and then divided right at the rectum. Took out the majority of your colon. Small bowel plugs in over here. We brought that up as an endoileostomy. So everything's coming up here, but your rectum's still sitting in place. Down low, it's just not doing anything. Okay? So the next time around, what we do is this is your ileostomy up here. This is your rectal stump down here. These are your sphincter muscles, the muscles that prevent gas and stool from coming out. Okay. What we'll do is we'll mobilize your small bowel, and we take, it's basically like a long tube. If you imagine a garden hose and you fold the end back on itself, I'm going to cut a little hole down towards that end, and we're going to fire a stapler up the middle and recreate this shape. So what's called an ileal pouch. So usually referred to as a J pouch because this is in the shape of a J. We're going to take out the rest of this rectum. It's just going to leave a short cuff and these sphincter muscles, and we're going to attach this down there. Does that make sense?
That's all in one surgery?
It's all in one surgery.
Okay.
So that's a completion proctectomy and an ileal pouch anal anastomosis, or a J pouch.
Okay.
This connection is very high risk.
Yeah.
So a lot of those don't heal up the way we want them to. And so in order to protect that while it's healing, because we want to give it the best chances possible that it has a chance to heal without having a bunch of inflammation and infection around there. And also, even if this doesn't heal, we want to try to minimize the chance that something, that your pelvis is so shot that we can't go back in there and redo something. So what we do is we create a diverting loop ileostomy. So we go above where this is located, I bring that back up through where your stoma's at, and we recreate your bag. So even though the pouch has been created and attached, stuff is going to still go out into a bag. And so after this operation, you will still wake up with an ileostomy in place.
Oh, okay.
See, I was.
I knew there was still going to be a bag after the second one.
And so, and it's also often not as good of an ileostomy as the first one. And the reason for that is that now all the, this, is not designed to reach down here to begin with. And so we're using every bit of length we can, which tethers it towards the backside. So that means that me just trying to pull it up through your belly wall is not that it even hurt, it's that I can't get the same degree of elevation that I can on this one. So trying to get a good seal with the pouch can sometimes be problematic.
So she won't have this same stoma, she'll have another one this time too.
She'll have another one, hopefully look relatively similar, but pouching may be more of an issue. This is also higher upstream. So the other thing we may run into is higher output. So you may dump more out of it, and you'll have to watch for dehydration. You may have to do antidiarrheal medications, all those sorts of things. So that's the second stage of the three that we've talked about. This was stage 1, this is stage 2. About 8 weeks later.
So you're just pulling this, you're not connecting it on this one, right?
We are connecting.
He's just creating another.
But my stool will be going out.
Out into a bag. This is unused for now.
Oh, okay, gotcha.
Okay? About 8 weeks later, if things are going well, we do a contrast exam in your bottom, inject contrast in your bottom and shoot x-rays. And I want to make sure nothing leaks out anywhere.
Okay.
And if we don't see any evidence of a leak and it looks like everything's healed up the way we want it to, that's when we schedule you to come back and close down your stoma. And that's when the stoma goes away.
How long does this surgery last?
This one's a few hours.
Is it long like the last one? Or
yeah,
longer.
Longer, most likely. This is kind of the big one in my book. The first one's to control your acute symptoms. The whole reason I don't do this one at the same time as your last one is because I want this one to go as well as possible.
Yes.
Okay? So, risks of the procedure, usual stuff related to surgery, pain, bleeding, infections. You have an anastomotic leak. That's that connection I was talking about. It's called an anastomosis. That doesn't heal up. That can leak stool into your belly. That's why we divert. Even if we do bring that stoma up, though, it can still be problematic and it can prevent us from closing this down when we want to. So there are things that we may have to do to try to correct that. Also a possibility in females of something called a pouch vaginal fistula. So the wall between your rectum and your vagina is very minimal. And if that staple line doesn't heal up very well, sometimes it can actually drill through to the other side, and that can be a difficult thing to get corrected. There's a possibility that I cannot get the pouch to reach, that your anatomy is just not, doesn't allow for me to get it down there. If that happens, I will open up your belly at that time, and I will try to do additional maneuvers to see if I can get it to get all the way into your pelvis. If I still can't, then there's a possibility we're looking at a permanent ileostomy. All right? All that being said, most people are satisfied with their pouches. So our studies would indicate between 80 and 95% of patients are happy that they underwent a pouch and would not go back to an ileostomy. Like those that do either had unrealistic expectations or had a complication like I just talked about.
Yeah. Okay.
What do you think?
I want to continue.
Still on board? All right. Sounds good.
Thank you.
You're welcome. And I'll be seeing you guys in the operating room, okay?
This is the picture that he was telling us about. This will be the next surgery. So all the stuff he was talking about in the drawing, this was the picture, you guys. So y'all, sorry I did not record anything when I was actually done talking to the doctors and whatnot, or walking out the office, but he said a lot, as y'all already know. I am nervous, so don't think that I'm not. I am. There's just a lot of emotions all in my head right now on how I feel about this next surgery. But at the end of the day, I want to give this a shot, you guys. Like, seriously. Sorry, I'm out of breath. I don't even know why. But y'all, just pray for me. They couldn't give me a date yet because it was pretty late. I actually was like the last patient to see him, so they couldn't give me my surgery date today, so hopefully I'll hear something from her tomorrow or Thursday to let me know when. I'm hoping they can get me in this month, because I want to keep this thing rolling, you guys. So yeah, it went good. I got some good answers. Nothing looked like from keeping me from doing the surgery, let's say that. So that's also a good thing. So I'm just hoping for the best with this route. A lot of people, I've heard great things about the J pouch. I think it's like 10%, 15% of people who didn't like it and went back to the ileostomy bag, or their permanent bag or whatnot. So I'm just hoping me, myself, and I will be in the category where it actually works for me, the J pouch. So yeah, just stay tuned, you guys. I'm going to also take you on the journey of this next surgery. So just get ready for this video, and keep me in your prayers. And I'm going to continue staying strong and taking this one day at a time, you guys. It hasn't been easy, but with your guys' support, my family, and of course my babe, I've been pulling through. So I just want to say thank you, and give this video a thumbs up and comment below, Team Moni. And until next video, you already know, I'll holla.